Hi, I'm Dr. Chad Duplantis. I have an aesthetic and restorative practice in North Fort Worth, Texas. And today I'd like to share a practice inspiration with you regarding treating the edentulous arch or arches. I call this a simple approach to a common problem, which is a loose denture. And I'm sure that many of us in our careers have had a patient come in and say, "Doc, I can't wear this denture, it's too loose." So let's talk about some options that we can incorporate to help with that. First off, I'd like to start by looking at some facts. More than 36 million Americans do not have any teeth, and that number is expected to rise over the next 2 decades. Additionally, in the geriatric population, the ratio of edentulous individuals is 2 to 1. About 23 million of this population are completely edentulous, and about 12 million are edentulous in one arch. 90% of those who suffer from edentulism have dentures. And the consequences of missing teeth include significant nutritional changes, obesity, diabetes, coronary artery disease, and actually some forms of cancer have been attributed to the lack of teeth. So what does all this mean? And the moral of the story is that edentulism is prevalent. We need to know how to treat these patients, and that requires us to educate ourselves in order to be able to appropriately treat these patients. And we need to offer these patients options in regards to their missing teeth and solutions. Our duties to the edentulous, in my opinion, are threefold, and it's the 3 E's. And really, this is not just to the edentulous, this is our duties to our patients in general. We need to educate. We need to educate ourselves, and we need to educate our patients. We need to manage those expectations of our patients and be realistic and offer options to our patients regarding treatment. And finally, we need to execute. We need to execute what we've educated our patients on, what we've managed their expectations on, and the treatment plan that we've come up with, we need to be able to execute it to the best of our abilities. We need to treat these patients appropriately, and we need to follow up accordingly as well. As far as managing expectations are concerned, the edentulous patient sometimes has some unrealistic expectations. But I always like to think of managing expectations in this way. In regards to a patient that is either dentate or edentulous, we need to remember that what we do, it is always better to improve a patient's chewing efficiency and quality of life rather than decrease the patient's chewing efficiency and negatively impact their quality of life. And that may sound kind of silly, but I'll explain it a little bit further in this next slide. I like to call this the floor-to-ceiling concept. When a patient comes into my practice that is either dentate or edentulous, and they want to change something about their current dentition, I like to explain to them that this is the floor and this is the ceiling. At the floor, you have your chewing efficiency, which would be about 0% if you had no teeth or no denture. The ceiling is the maximum chewing efficiency, and it's what you would have if you had all of your natural teeth. Take it one step further, your natural teeth are perfectly healthy, and you can eat whatever you want, you can do whatever you want. That's the chewing efficiency that you would have with your natural teeth. That's the ceiling. In between, if you were edentulous on the lower arch and we added just a lower denture, you would have about 10% of your maximum chewing efficiency. If we added implants and created an implant overdenture, you would have about 60% of your maximum chewing efficiency. And if we made it to an implant-borne bridge, either a hybrid or individual implant bridges to replace the missing dentition, you would have about 90% of your maximum chewing efficiency. So I explain this to the patients when we're talking options as far as treating the edentulous arch. When we think of options, we have several options, and our patients know many of those options by heart because they see it on the television, they hear it on the radio, they hear these wonderful, life-changing stories about these patients that go in and they leave that same day with a whole new set of teeth, and they're screwed in, and they're perfect, and they're going to last a lifetime. Unfortunately, what those commercials don't tell us is they don't tell us that the cost associated with it is quite substantial. The desire of all these patients, as it would be for most of us, especially when you start explaining the floor-to-ceiling concept, is they want the implant-retained denture. And there's several options of several different costs as far as that set of options is concerned. You have your secure fit or conus attachments, you've got your individual implant bridges, and you've got your much talked about, much researched, much utilized in dentistry, the all-on-4 concept. All of these are extremely viable options. But once again, the reality with these options is they're very costly. And patients, once they hear the cost, sometimes they back off a little bit and say, what are my other options? Now, there's other options in between, but the reality is that a lot of these patients, what they can afford and what they need is a denture. And so I like to tell these patients that I can get you into a denture, we can get you comfortable, and then we can talk about other options down the road. So let's get that step out of the way. I personally like making dentures. I know that many of us don't. I know that many of us see it as the dreaded denture, and it's something that they really don't want to have in their practices. But I like this, and I think it's a great practice builder, and I think it allows us for a future with those patients and endless options afterwards for many of those patients as well. As a matter of fact, I've had great success in my practice making several people happy by just spending a little time with them and making them a denture. And both of the patients that you see here, they have dentures, but they know that down the road, they're going to go for implants, or at least that's what their goal is, because we've talked to them about their expectations and their options. With dentures, we also have problems, and there's 5 common problems associated with dentures. 1 is chewing efficiency. Number 2 is that the taste can be affected or altered. Number 3 is gingival irritation or soreness. Number 4 is continued bone loss or resorption. And number 5 is they don't stay put, so retention is an issue. Now, if we look at these 5 problems with dentures, and I think that if we've ever done a denture in our practice, even in dental school, we could relate to every single one of these. We can help them with their chewing efficiency. We can help them with their gingival irritation or soreness. We can help them with their continued bone loss and resorption. And we can also help them if they don't stay put and retention is an issue. The one wild card in this scenario is the altered taste, or the sensation of taste being altered. That's the wild card, because is that related to the patient or is it related to the lack of teeth? And each patient is different. And it is a complaint that you will get sometimes, and it's something that I always promise my patients that I'll try my best, but I don't know that I can make any changes to that. I also always tell my patients, I can make your upper denture fit. I can make you a really good upper denture, but the lower denture will never fit. You must adapt to make this denture functional. This is easier for some and harder for others. And once they agree to that, once they understand that, it makes life a lot easier. So what's the solution to the ill-fitting or the loose denture that helps us solve 4 of the previous problems? And it's the implant-supported overdenture. This is a great option, which is mostly financially feasible for patients that are interested in gaining more support for their for their denture, and allowing them affording them more retention. Implant overdentures have been around for a while. They're a safe and highly effective long-term treatment option. They have an extensive history of clinical use. They have favorable patient satisfaction. However, appropriate treatment planning is vital in order to make these successful. Stability increases with the increased number. 2 locators would be the minimum, and 4 locators would provide the best retention for that particular arch. Zest has been the manufacturer of locators for a number of years, and they're kind of the monopoly in this area. But they have the Legacy locator, and recently they've introduced the Locator RTX. And rather than read to you all the differences in the Legacy locator versus the Locator RTX, I'll point out a few that I find really made some profound impacts on providing locators as a retentive element for dentures. The first is that the new locator does not require a custom tool for the particular locator abutment. It requires a standard 0.050 inch driver or a 1.25 millimeter driver. Additionally, as opposed to the previous locators, which had only a 20 degree maximum divergence between the implants, and that was with extended range inserts, a 10 degree maximum with the standard inserts. In opposition, the new Locator RTX offers or allows a maximum of 30 degree divergence between implants, and you'll still get an adequate fit and adequate retention. And finally, with the older Legacy locator, they had standard and extended range inserts, and the retention was measured in pounds. On the new RTX, there's only 3 inserts, low, medium, and high retention, and there's not different different standard or extended ranges, so it really simplifies the process in treating these patients. So let's take a look at how this works with a patient in our practices. First off, the patient's been wearing their current denture for a number of years, and they've decided they want to go with implants. So I send them over to the surgeon, and the surgeon sends the patient back after appropriate healing. We were able to relieve their previous denture, so they show up with healing caps, and they're ready to move forward with their locators. At that point in time, we must select the appropriate locator abutment to fit to those implants. It's real simple to do. Remove the healing cap and use a periodontal probe. Measure the height from the abutment to implant interface to the highest point of the gingiva. If this is 2 millimeters, then you'll select a 2 millimeter cuff height abutment. If it's greater than that, then you'll select whatever the height is to the highest point of that gingival tissue. An additional 2 millimeters of the abutment will extend above the tissue at that point in time. And so here's the abutments in place, and you may look at that and say on the labial aspect, it looks like there's a lot of the cuff exposed. However, if you look at the lingual aspect of these implants, you'll notice that the tissue was measured to the highest point, and the abutment is almost flush with the tissue on the lingual aspect of these implants. So that's how we gathered that this was the appropriate abutment height. Additionally, you've got the abutment and you've also got the processing attachments. The processing attachments on the new on the new Locator RTX are anodized, and they also have a processing insert in them. Those are placed on top of the abutment, and there's actually a ring underneath that will keep these from getting the denture locked on while you're processing the attachments. I utilize a Danville microetcher, and so I don't really care that they're anodized, although they are. I think that's great. I want more micro retention, so I'll use a Danville microetcher, and I will go ahead and microetch these to increase the amount of retention available for these attachments to be processed. At that point in time, I'll re-relieve the denture. It's already been relieved throughout the healing phase of the implants, but I'll re-relieve it, and I want to verify that this denture fits passively over the abutments and the processing attachments. I'll also place 2 vent holes on the lingual aspect of the denture so that when we pick up these abutments, the material that we use to do so will actually be able to vent through the lingual surface of the denture. And once again, as you can see, I'm a big fan of the microetcher. I'll use the microetcher to help with the retention of the processing medium and the processing caps to the denture. This next phase, there's a couple of different products on the market. The one that I happen to use is chairside attachment processing material. There's no primer required. It's bisacral. There's a mechanical bond. It's dual cure. It's odorless and tasteless. It's very predictable and very easy to use. The other thing is, as opposed to acrylic, it does not heat up and is not uncomfortable to the patient throughout the processing. We squirt a little bit into the relief holes that we made. We go ahead and place the denture on top of the processing attachments. We allow it to we light cure it to tack cure it, and we allow it to dual cure. I usually leave it in there for 5 to 6 minutes, and then I remove it. And the next part is that we remove the processing inserts, and we go ahead and we place our retention inserts. Now, my suggestion to you is that you start low and go high. I always start with the lowest retention insert. I check the patient a week later, see how they're doing. If they're doing great, we leave it in there. And we change these out usually once a year, and sometimes we don't even hear back from these patients for 1.5 years, 2 years, and they'll let you know, trust me, they'll let you know when the denture loosens up again. And we can either go with the same retention insert, or we can actually go one step up. My caution is that if you start with the highest level of retention, that patient's going to become accustomed to that fit, and you don't have a next level to jump to. Now with this, we were able to create a retentive denture from a loose denture. It was minimally invasive to the patient. We only had 2 implants. It was cost effective, and in the end, we get a very, very happy patient. In closing, I'd like to tell you that with a few simple steps, you can quickly become a hero in your patient's eyes. These additions to an existing or new denture can drastically improve the patient's chewing efficiency and in turn their quality of life. I want to thank you for your time, And I hope that you found something in this that inspires you with your denture dentistry. Thank you very much.